when you have a 4-year-old and I say that their upper and lower extremities are appropriate for development in age, you're not going to see that if they have muscular dystrophy. You're not going to see that if they have cerebral palsy. So it tells you a lot, just that statement. Tremor. There are two broad categories of tremor. One is intention tremor, that if they're still, you don't recognize it. It's only when they reach for something, and you're going to get them to reach here in a minute, that you start noticing the tremor. So if I were to pick up my coffee cup here, as I move towards the cup, the tremor, the more refined I try to make the movement, the worse the tremor gets. If I stop moving, the tremor goes away. The cerebellum is largely responsible for coordinated movement. So if a person has an intention tremor, the first place to look is the posterior cranial fossa, the cerebellum. The resting tremor is what's seen in two types of, basal ganglia lesions. Basal ganglia we'll cover later on. They're deep brain structures, they're deep brain nuclei that allow you to have muscle control but not moving. So right now you're sitting here not moving, yet you have dozens and dozens and dozens of muscles contracted that allow you to sit up in your chair although you're not moving. A problem with the basal ganglia releases those muscles so that you can't control them in a stationary way. So you start, even though I'm standing here with my hands not moving, I have a resting tremor. The resting tremor of Parkinson's disease looks like I'm rolling a pill between my fingers. That's why it's called pill rolling. That's the early signs of Parkinson's disease. As it gets worse, the amplitude of the tremor gets higher. And then you start picking up other muscle abnormalities related to Parkinson's that I've listed there. Cogwheel rigidity is, so you know what a cogwheel is? Like if you open a watch and you see all the little wheels with teeth on them, that's a cogwheel. So ordinarily, if I put it on like that, so resist me a little bit, not much though. So not that much, just let it come down. So you see how smooth this is? He's resisting it. Now go ahead and contract it back up, right? You see how smooth that is? In Parkinson's disease, they lose the ability to make that a fluid movement. And instead of it being fluid, it does like that. So do my arm, so like that. So if I try to contract it, it comes up like a cogwheel, like a cogwheel. Okay. So also you're testing. A flattened affect is their face loses expression. They don't have the muscle tone in their face any longer to give them that expression. So it looks just like Deputy Dog, you know, that thing with if you look at Muhammad Ali in the later stages of his life, you look at his face, he has no expression. The year that he lit the torch at the Olympics, I mean, who would not be just crazy wild, happy to be the person to light the torch at the Los Angeles Olympics. If you looked at his face, he had no emotion on his face because of his advanced Parkinson's. They also have a shuffling gait, and they're stooped over a little bit. They get stooped over. Instead of putting the heel and then rolling up onto the toes, they pretty much just, they plant their feet flat. And then, arrested gait, they'll stop. And they'll just stand there until something clicks in their brain and they start moving again. And they can stand there for a long time. If you see somebody with advanced Parkinson's and they're just standing there, come up behind them and give them a little push with your finger, because that's all it takes to get them going again. They can't say, hey, I'm stuck, will somebody push me? You just push them. Okay? And finally, the resting tremor. It can be quite severe. When they go to sleep, it goes away. These are all the signs of intention in resting tremor. There's one other tremor that is very common. That's called familial tremor. Familiar tremor it looks a lot like this. It's more of an intention tremor, but it's also a resting tremor. That's the reason, and it runs in families. I've got a good friend I hunt with that he has a pretty bad familial tremor. It's in his family. Interestingly, a couple of beers and it goes away. That's how you can diagnose a familiar tremor. Tell them drink 2 beers. They go away, you got familiar tremor. Any questions about that? All right, muscle tone is in the neuro exam. You want to just test tone, not strength. So when you put your hands on them like that, you're testing tone. The other way to do it is to just do like that cogwheel rigidity. Can you just contract against my hand? Just contract, contract. And just do it on the other side. Contract against my hand. Okay. If you have neurological issues, you don't do that smoothly. There can be clonus or cogwheel rigidity. It should be smooth. We'll get into clonus in neuroanatomy later on. You do it in the upper and lower extremities. As they're sitting on the bed, just put your hands on their shins, push out against my hands, pull back in against my hands. You're just testing tone. You can also test fine motor movement. You're going to test this later on by just having to, can you do this? Do that. Put your thumb to the fingertip, go down and then back up. Or as they're sitting here, tap the stool or the floor. Strength is something we're going to be dealing with in the musculoskeletal section, along with range of motion. I put it in here, though, because you're really, I mean, why would you test one and not the other? You can do these at the same time. For example, if I'm, can you just come up here and sit right here with your legs this way? So if I'm testing tone and strength, right? So I come up here, shrug your shoulders, right? I get to the end of my cranial nerve, turn your head that way, turn your head that way, stick out your tongue, push your tongue against my cheek, do it the other way right there, okay? Now I'm just feeling her arms like that, feeling her legs like that, okay? Put your arms like this, push up against me, down against me. I'm testing tone. Push out, like I said, pull back in, okay? Put your arms out, pull back in. Put your hands like that, push up again, bend, I want you to bend at the wrist, push down at the wrist. Touch your thumbs to your little fingers like that. Don't let me pull my fingers through there. Okay. Grab my fingers, squeeze them just as bloody hard as you can. Some people will cross there and grab my fingers, squeeze them just as bloody hard as you can. So you understand that I'm testing tone, but also testing muscle strength. They go hand in hand. And you do the same thing with the feet. I did the push out, pull back in, push up against my hand. Push up against my hand there. Push up, I'm gonna push up with your foot, push down. Do it over here, push up, push down. And if I had her toes, I'd put my finger on her toe. Push up against my finger with your big toe, push down against. So, okay. So that's why I put it in here. Now you rate muscle strength on a scale here of 5, and the criteria are listed there. If you say muscle strength is symmetric, appropriate for development and age, that gets you the answer. Okay? If there is weakness, if there's asymmetry, describe it. That's the easiest thing. Just describe it. The individual muscle groups here, you can say this for musculoskeletal, are listed here. And I put the nerve in there, that tells you the nerve it's testing. Very simple. When you go from the arm down to the hands, that bottom part there, when you go from the arm or the shoulder down to the fingers, that's essentially testing C4 all the way down to T1 in that general pathway. The lower extremities are here. You need to test these things during your assessment. Sensor. All right, so there are two types of sensation, as I mentioned, or two pathways for sensation that I mentioned. The first one is where it's the second bullet point here, pain. This is carried over a pathway called the spinal thalamic tract. It's called the lateral spinal thalamic tract. That carries the sensation of pain and temperature. All other sensation is carried over under light touch with the dorsal column. All of the other sensations that you see up there are carried by the dorsal column nerves. And you're going to learn when we do the spinal cord here in a little bit, that they're located in two parts of the spinal cord. To test light touch versus pain, use a Q-tip and a broken end. Now understand that this is pain. This is not hard touch. It's got to be painful. If it's hard touch, it's not spinal thalamic tract, it's dorsal column. It has to be painful. So the way you do it is, I would have, let's go back over here. We're just going to do it at the lowest dermatomes. Well, actually, all my stuff is over there. I'm going to go over there. Allison. So what you do is, you're testing, if we just sit up there, you're just going to test the lowest dermatomes. The upper extremity and the lower extremity. If there's a problem, then you can move up in the dermatomes. So I want you to hold your hand out like that. Now, I'm either going to touch you with this Q-tip or the pointed end of this. Right? I want you to tell me, is it sharp or dull? Don't say, is this painful or dull? Say, is it sharp or dull? Okay, close your eyes. Okay, that's it. I tested, but you have to test both of them on both sides. Then I would go down here and repeat that on the foot. And you can test them anywhere on the hand. The fingertips are the most sensitive places, so that's where I go. A lot of people will test the back of the hand, but it doesn't matter. If there's a problem, then move up the dermatomes. Okay? Same thing down here, move up the leg, the lower extremity. The next thing is, if there's a problem with touch, then we can, if there's a problem with pain, if she cannot feel pain, then you can verify that by taking the test tube, filling it with hot water and cold water, and testing temperature. Is this hot or cold? And put the two different temperatures on the same dermatomes. I've never tested hot and cold in a patient. If you can't feel sensation, if it's not diabetes, you're going to get a CT. Okay? But if there is an issue with touch, let's test the other ones. One of them is vibration. Vibration is the first sense to go in diabetes. So what you want to do is hold out your hand for me. You want to take the tuning fork and click it on your hand. A lot of you people are having a hard time getting, just thump it on your hand right there, okay? Now I want you to tell me, is this vibrating or not? Put it on a bony prominence. I'm going to put it on her level, her MP joint of her second finger. Why are you looking at it? All right, so is it vibrating or not? Yes. Now what you also want to do is, if I'm sitting here doing this, she knows I'm doing this, what you also want to do is say, is this vibrating or not? No. But you're only testing touch now. You still got to do it. How about now? Okay, yes. So you're testing her, oh, I can hear that thing, so I must be vibrating. And then do it on the big toe. Big toes. She has two. Okay? 2-point discrimination is, I want you to close your eyes. Tell me where I'm touching. Yeah, the knee and shoulder. She's able to synthesize that I'm touching her in two places across the midline, knee and shoulder. You only have to do that once. You don't have to change the direction. Just do it once. And proprioception is the last one here. And what you do with that is I'm going to take your finger, put your finger on the side of their finger like this. And I'm going to raise it up and down. I want you to close your eyes, and I want you to tell me, is your finger pointing up or down? Right now. The other side. Up or down? All right, and then do it with the toes. Do it with the big toes. Is my toe pointing up or down? And that's proprioception. Okay? Any questions about any of that?
So you said start distally, right? Do we still have to work proximally if it's normal distally?
No, if it's normal distally, you're done. If you've got the lowest points of the nervous system, everything else above it's got to work. There's only one instance where that doesn't come into play, or a couple of instances, but on a survey exam, that's all you need to do. Okay? Cortical sensation, there are different types of cortical sensation. One is graphesthesia, and so with graphesthesia, I'm going to take your palm, close your eyes, and I want you to, I'm going to draw a number in your palm. Tell me what number I draw. 8. And you do it to the other side. Yeah, perfect. Okay? Don't make a complicated number like 4, like this kid. Make it an easy number, like, 2. Okay, or 8. The second thing is stereomagnosis. Close your eyes, hold out one hand, put an object in the hand like we did with over there. Tell me what that is. Okay, with your other hand, and you put another object in your other hand over there. All right, and don't do oddball objects, something very simple, okay? Tactile extinction is like 2-point discrimination, except what you're doing is, a lot of people will say, okay, close your eyes. Now I'm touching your 2 points. Do you feel those? Tell me what they are. Which one did I remove? Okay? That's tactile extinction. 2-point discrimination, tactile distinction is essentially the same. Okay? Thank you, ma'am. These are higher cortical functions, being able to do that.
I thought that 2-point discrimination you do like on a fine point, or you touch like 1 point on something that has
You
2
can do it with this,
Okay.
but it's the same as that. Okay? Reflexes. Are you guys okay with reflexes? Have you guys been through reflexes? You haven't been through reflexes? Okay. So reflexes, you number these 1, 2, 3, 4, 5. Clonus is if I if you write down. So clonus is if I take her ankle and I do this, I force it up like that. You see, she doesn't do anything, right? It's got to be hard. It's got to be hard. This is brutal. So in a person with a neurological deficit, especially involving the brain and the spinal cord, what they'll do is that when you do that, she'll push down against me. When you do that, she'll push down against me. That's called clonus. It's a resisting type of thing. That's called ankle clonus. Thank you, ma'am. Normal reflexes are 2+. So you can, when you're writing reflexes, you're going to test reflexes in at least 5 places. The ankles, the knees, the biceps, and the triceps, and the brachioradialis. You can, instead of writing this out, with an EMR, you would have to write it out, but you can draw it out if you're like that. You get the picture, right? And again, they should be symmetric. If you don't have good reflexes, you could say 0 or 1+, they're hyporeflexic, but as long as they're symmetric, that's fine. If you have a neurological lesion, they won't be symmetric. And we'll go over this later on. So to do the reflexes, anybody here know they have good reflexes, so I can demonstrate it? Okay, so come on up front here. So remember from anatomy, it's spinal cord level wise, it's 1, 2, 3, 4. S1, 2 is the ankle. L3, 4 is the knee. The biceps is C5, 6. The triceps is C7, 8. And the brachioradialis is the lower cervical as well. Okay? So to test the biceps, you put lay their arm over yours and put your thumb on their biceps tendon. And then with the point, you tap your thumb. and you have to have them relaxed and let your arm fall. And what I can do, if you sense that they're holding their arm up, just remove your arm. And if they still have the nose, see you have your arm up, I need you to relax it. Just let it go. You see your arm twitch? You can see it twitch here, and you can see it twitch there. Okay? While our arm is here, the brachioradialis muscle, flex your arm. There it is right there. So it's ending right here. All you have to do, since the arm is right here, just relax, is tap right here. See your arm? Okay? There's one in the head. The triceps, hold their arm up, let it relax, and just tap right here, the triceps tendon, and don't stand here. Because she'll wrap you in a noonie. Stand away. You see her, you can see the triceps contract up here. It's behind. Can you see that right there? It's actually kind of cool. Turn around. Go this way. What's right here? You see her arm moving down here, right? I'm not getting it to. There you go. You see that? See that? That's that one muscle belly right there of the triceps. That's kind of cool. And then the patella, it's just the patella tendon. Some people, if you can't get it to do, if you tell them to hold their arms like this, pull as hard as you can. For some reason, that exaggerates this reflex. Okay, but you've got a crazy one. The Achilles is you come down here and so you get them to relax their foot and then dorsiflex it a little bit and then tell them to push down just a little bit. Push like you're pushing on the gas just a little bit. And then you tap the patellar tendon back here. You see she's got it pretty brisk. Okay. While she's here, there's a reflex called the Babinski. Have you heard that? Babinski? While you have her foot, you take this. Okay. Take this part of the hammer, put it on the heel, and run it. Kind of move your. Run it along the outside of the heel of the foot, and then across the metatarsal heads. So, if there is an upper motor neuron lesion, and I'll explain this later on, if there's an upper motor neuron lesion, the big toe will point up. The toes will fan out and the big toe will point up. Ordinarily, she won't do anything or she'll curl her toes, but in the Babinski, they flare the toes and the toe points up. Okay? So you need to practice with each other on how to do these reflexes because you need to get good at that. And again, if a person doesn't have good reflexes, it's fine, as long as they're symmetric. Now, upper versus lower motor neuron disease. I'm going to save this to the spinal cord discussion later on this afternoon, or this morning, I can't remember which. On the illustrations on the right, though, it tells you about two different types of reflexes. On the bottom panel, we showed you the deep tendon reflexes. And the reason you have deep tendon reflexes is because you have two things in your muscles and tendons that regulate muscle contraction. They're called Golgi tendon organs and muscle spindles. Those things have afferent nerves that send information back to the spinal cord on how contracted your muscles and tendons are. The reason a reflex works is because, for example, the patellar tendon thinks it's straight up and down. It thinks it's straight up and down. Here's the muscle, here's the tendon. And then all of a sudden you hit it with a hammer and you deflect it like that. That activates your Golgi tendon organs to say, wait a minute, the leg suddenly, or the lower extremity suddenly is not where it's supposed to be. And in order to fix it, in order to fix that deficit, you try to tighten the muscle to straighten that back out, and in doing so, your foot goes forward. This is a deep tendon reflex. When you hit a tendon, the five that I just went over, that's what happens. And it's a protective mechanism, because if you're like walking down the stairs, and I know I'm walking down the stairs, and my tendon, my proprioceptors know where my legs are in space, right? And all of a sudden I miss a step. I don't fall because suddenly my tendon organs and my muscle spindles tell my spinal cord to tighten up. That prevents me from falling. That's the same mechanism as a deep tendon reflex. The top panel shows a cutaneous reflex. A cutaneous reflex is the one that you've always known. That's put your hand on a hot plate and you withdraw it, right? You have cutaneous reflexes all over your body as well. One of them that we talked about in anatomy, we did not demonstrate it, was the cremasteric reflex. You run your hammer, the handle of your hammer down the inside of the leg, and the testicle will rise out on that side. There are other cutaneous reflexes. Probably the most important one is called the anal wink reflex. This is a person who is comatose or has significant neural trauma. Your anus is your lowest dermatome, right? So if you look at a patient's anus, that's the anus, and you take a cotton tip applicator and you stroke the anus on one side, it should contract towards that side. If you do it on the other side, it should contract the other way. That's called the anal wink reflex. In patients with spinal cord trauma, go there, you need to do it. Okay, I'm going to leave it at that, and we'll pick up upper versus lower motor neuron disease as it relates to deep tendon reflexes later on today. Here are the ones we talked about. The Babinski, there's not a negative Babinski. You either have it or you don't. So there's not a positive Babinski. The Babinski reflex is present. If you're reporting it, you would say no Babinski reflex. You wouldn't say negative. There's no such thing as a negative Babinski. Moving into coordination, let's look at cerebellar function. All you want to do with cerebellar function is get things moving. The easiest way to do it is, Ron, touch your nose with your finger. Now touch my finger with your finger. Back and forth, back and forth, back and forth. And you move it side to side. And do it to the other hand. Do it to the other hand. There you go, back and forth. If he has an intention trimmer, he will not be able to do this. Okay? Touch your heel, run this heel down that shin. And do it the opposite side. Rapid alternating movements. Put your hands on your lap, on your thighs, and flip them over, flip them back, as fast as you can. Okay? This again works as well as tapping the floor. Just get the body in motion. That's all you got to do. If you want to have them, when you do this, just you know, get the body in motion. You definitely want to test gait. I always have them walk to the door as I'm watching them. This also tests muscle strength, obviously, and you're looking for a Trendelenburg gait. Remember that from anatomy? Then you have them come back heel to toe. To be able to do this requires not only muscle strength, it requires coordination, it requires cerebellar function, it requires vestibular function, it requires cerebral function. There's global tests. When you get back, I want you to stand on one foot for 5 seconds, hop up and down on that foot. Now do it the other side. Stand on one foot for 5 seconds, hop up and down. The last thing is Romberg. You put your toes and your heels together, put your arms straight out to the side, and close your eyes. Now, when I do this right here, I'm going off of visual cues to help my vestibular nerve, my basal ganglia, my motor systems keep me here. When I close my eyes, I take away the visual cues. Now I'm just relying on vestibular nerve to know where I am in space, and people with cranial nerve 8 problems will fall. It's interesting when people have sinus infections or ear infections and they've got a lot of fluid in their ears, in one ear in particular, that you're looking at your ear and you see all this fluid, and they come in complaining of pressure in this side of their head. If you do these tests, they will be positive. They will fall to the side of the fluid, the Romberg. If you get them to walk towards you, heel to toe, and close their eyes, they will fall towards the side of the fluid. It's a vestibular test. Make sure that when you test the Romberg, though, Allison, just stand up here. So, face that way. So, it's part of the, again, putting the neuro with the musculoskeletal. When I get to this point, I say, okay, I want you to bend over, touch your toes. Okay, so I'm looking at her spine, right? I'm looking for alignment. Come back up slowly, and looking just for kyphosis or scoliosis, right? Put my hands on your hip, bend back towards me. Okay, straighten up to the right, to the left as far as you go, and then straight, turn around, look at me. Turn all the way around. Okay, turn around the other way, look at me. So that's fine. When we get to musculoskeletal, that's fine. But it's also the nervous system, right? Okay. And then I want you to walk to the door. Walk to there. Okay, turn around. Walk back. Good, right there. All right, stay right there. Come over here. Stand on one foot. Hop up and down. Stand on the other foot. Hop up and down. Put your toes and heels together. Put your arms way out to the side. Close your eyes. And come in here like this. Okay? Don't touch her, but come in here like this in case she falls. You can open your eyes. Put your arms down. Okay? It's so funny when, if you don't tell them exactly, sometimes they'll, when you say, okay, you can open your eyes, and they'll stand there with their arms. You put your arms there. But always put your hands sides in case they start to fall and grab. If you do go to YouTube and just look at Romberg and look at Babinski, you can see what these different reflexes are.
Does falling any particular way besides when they have a sinus infection indicate anything else?
No, they just
Fall in
yeah,
general?
they just
Okay.
fall. Yeah. Okay. Certain diseases, a couple of diseases we'll just focus on here. Meningitis, we're going to talk about CNS infections later on in the week. But the two tests for meningitis are Kernig's and Brzezinski signs. You see Kernig's on the right. You just have the patient, you flex their hip and then try to extend their knee. And this puts stretch on the meninges, and they don't want to do that. Or put stretch on the nerves, which stretches the meninges, and they don't want to do that. They're resistant. Brzezinski's sign is you have them lying down flat, and it says passive flexion of the head. This is the term you need to know. If I move it, it's passive movement. If I ask you to move it, I want you to flex your neck, that's active. So by passive, that means I lift the kid's neck. And when you do that, they draw their hips up, hips and knees up, to try to take the stretch off of the cervical meninges. The triad there, a fever, headache, and neck stiffness is, should alert you to meningitis. Always be quick to pull the trigger on working up meningitis. Guillain-Barré syndrome is an odd duck. I've seen it several times in my career. It follows usually a viral infection. It can follow immunizations, and it can follow infection, diarrheal infection with a bug called Campylobacter. C-A-M-P-Y, that's the genus name, Campylobacter. Diarrhea. Campylobacter jejuni is the species name. And what it is essentially is a shutdown of the nervous system from distally to proximal. It's an ascending paralysis. I had a medical student one time came in complaining of paresthesias in both of his extremities and a little bit of weakness. Turned out he wound up with Guillain-Barré. Remember, there's not a whole lot of things that will give you bilateral paresthesias. Diabetes is one, syphilis is one, Guillain-Barré is one, so these things you have to keep in your mind. Ataxia is uncoordinated gait because you're losing muscle strength and sensory function. If it ascends all the way up to C4, it'll paralyze the diaphragm and you go on a ventilator. It's a self-limiting disease most of the time, and function comes back over days to weeks, maybe a month, and it comes back opposite the direction it came on. So that you start getting function in the cervical region and it descends. Cauda equina syndrome is something you have to just be on guard for anytime somebody complains of back pain. And what this is essentially a compression of the cauda equina. The cauda equina, beginning up here in the lumbar region, is going to affect the lower dermatomes. And the pathognomonic feature of cauda equina syndrome is saddle numbness. So if somebody comes in and they are complaining of numbness in this area, then you need to image that back to rule out some type of growing tumor in that part of the spinal cord area. Eventually, if it's not corrected, they wind up with bladder and bowel issues because it knocks out the autonomics. decreased retro tone that essentially just shuts down the descending colon. The S234 descending colon, parasympathetics. If you ever hear the terms saddle numbness or saddle anesthesia, the answer is going to be cauda equina syndrome. There was a PA that was sued and lost because there was an inmate in the jail that had been in a fight, and he wound up going to the infirmary with saddle numbness, and the PA didn't pick up on it and wound up with cauda equina syndrome. And obviously, any type of nerve syndrome like this, if you don't stabilize it and fix it, it becomes permanent, and that's what he wound up with. So he lost that lawsuit. Any questions, again, about anything going on in your life? Okay. Take a break. I'm not sure if Latassi, no, one more thing. On the on D2L, you have the mini mental status exam. This is on this D2L. You'll see that there are 3 columns there on the right. Because you're doing this over time, you can do it acutely in the emergency room, but one of the things about things like dementias is that they're slow progressive disorders, and you want to do repeat measures of mental status over time, and that's why there are 3 columns there. The other thing that's on the server, this is not what I want, that's on the server obviously, is this right here. That's not what I want to pull up. In your, wait, there it is. In your handout that you have from earlier in the year, you should have this from earlier in the year, is the entire physical exam. You have that right? So this is just the excerpted portions of the nervous system. So this is everything we've gone over in an organized fashion. So you'll need to get this down. Starting with the mental status exam, moving into the cranial nerves, and then motor regarding tone, fine movements, sensory, and here they describe sensations at these lowest dermatomes, graphesthesia, stereoagnosis, the reflexes are here, and then coordination, gait, balance. So that's essentially everything I've gone over in a systematic way. Okay, it should take you, here, let's do it real quick. So it should take you to do this, if you'll sit up here, just a few minutes to do the entire nervous system. Come over here, so I get to so if we've done the Folstein mini mental status exam, she scores a 30. And you're, obviously everybody here would score a 30. The next thing I'll do is just run through the cranial nerves. Okay? Put your hand up. Breathe in. Breathe out. Okay. So I'm going to take this right here, cover one nostril. What does that smell like to you? Okay. Cover the other nostril. Grab a thing of cloves. I like cloves. What does that smell like to you? Cloves. There you go. All right, we're going to do the checker eyes, right? Real quick. One thing I didn't mention was the direct and consensual light reflex. And by the way, you want to get them to do this test before you shine the light in their eyes, okay? Either with the fundoscopic exam or the direct and consensual. And we'll talk about in neuroanatomy why this happens like this. So look at my nose, all right, I'm shining it in that eye, I see that eye contract, the pupil constrict. Now look at the other pupil, and I watch that one constrict. And then I go to this side, like that. So you have to do each eye twice, right? A lot of people in these previous exams were just doing it once and shining in that eye and then looking over here. No, it has to be done twice in each eye, okay? Just look at my finger right here and just follow it with your eyes. Keep your head still. Follow the finger. There you go. All right. Okay, follow it in. Follow it out. Okay, cover your eye. We can check. Can you see that right there? Can you see that right there? Cover the other eye. Can you see that right there? Can you see that right there? Okay, good. All right. So that's all cool, right? Okay. Pretty dry, that's one. Both. Oh, you got a little thing going on here, huh?
I can go.
You, really? Oh, there you go. You got them. Okay, back down real hard. Chest ambassador. Smile for me. Is she smiling? Frown. Okay, puff out your cheeks. Stick out your tongue. Shrug your shoulders. Turn your head that way. Turn your head that way. Okay. So I got most everything done right there, right? The only thing I'm really missing is she's talking to me, so I know 9 and 10 work. If you want to check her year ago, that's great. You ought to do that. You probably did it when you did the oral exam anyway, right? The next thing is 8. We didn't test 8. Close your eyes. Can you hear that? Can you hear that? Okay. All right. So all of that's cool, right? I'm just going to come over here, lay my hands on her, checking tone, right? Down her thighs, down her calves, okay? Hold your arms like this, pull up, pull down, push out, push back in, okay? Put your arms like this, okay? Again, going through the same thing I did with down, okay, over here, up, down, put your thumbs like that, your thumb with your little finger. Don't let me pull my hands through there. Grab my hand tight and squeeze as hard as you can. The other thing you can do is the abductors and adductors of the fingers. Do like that for me. Don't let me push your fingers together. Resist, resist, resist. This is checking the interossei, right? This ulnar nerve. Now put your fingers together. Don't let me pull them apart. Resist, resist, resist. And you got to give them a second to figure out, because this is not automatic. Okay, good. Right. We do the same thing in the lower extremities. With the ankle, push up, push down, down. With the big toe, up, down, down. Okay? Great. Can you stand right here for me? Walk that way. Come back heel to toe. Good. Stop right there. Put your toes and heels together. Arms up to the side. Close your eyes. Yep. Open your eyes. Hop up and down on one foot for me. The other side. Okay, sit right here for me. This is sharp. That's dull. Tell me which one you feel.
Sure.
Okay. You gotta test both of them on each side. And then we do it down here in the lower extremity. Okay? We can go through vibration, but the sharp and dull is intact. Vibration, 2-point proprioception are going to be intact. But for the purposes of this exam in here, you need to demonstrate that. And then we'll just go through the different deep tendon reflexes. And that's pretty much it. Okay? Now there are some specialized tests in neuro that are looking at things like stroke. And one of them I want to mention is in stroke, the 3 things that pop up first are facial muscles, drooping face, speech problems, and a thing called pronator drift. So hold your arms out straight in front of you, your palms up, put your palms flat. Okay, now close your eyes. If a person has had a stroke on this side, this arm will start to rotate inward and drift downward. And maybe drift inward too, like that. That's called pronator drift. It's a sign of a cerebral infarction or cerebral trauma. Okay? Any questions? All right, pretty straightforward. So let me find out if I'm preaching or the passing, and then we'll move on.